In this video clip, we'd like to provide you with some information and first-hand insight into the types of patients we're looking to recruit into the tactic trial. Joining us to discuss this is Dr. Laura Jane Smith, consultant in respiratory and internal medicine at King's College Hospital. LJ has a specific research interest in breathlessness in respiratory diseases. LJ, you've been pretty busy over the last few months, so tell us a little bit about the phenotype of the patients you've been seeing coming through the emergency room at King's College Hospital with coronavirus infection.
So we have been very busy. We've seen a lot of patients with coronavirus. Typically what we'd see is people describing a few days of symptoms such as a scratchy throat, developing into a fever and a cough. Later they'd be having some other symptoms, perhaps of breathlessness, and often they're the people who we're then seeing in hospital.
How do you see these symptoms evolving, particularly early on when the symptoms are very recent onset to perhaps when you see people in the emergency room who've had symptoms for a little bit longer? What does that look like?
So in the early phases, what we're seeing is people generally have mild symptoms. Often actually the first symptoms are things like loss of smell and taste, and that's been really prominent. Later the cough and the fever then develop, perhaps after 3 or 4 days. And then there's a period of time between perhaps 7 to 10 days when some people certainly deteriorate, and often they present to hospital breathless during that period. And then often, if they are going to have more severe disease, some of the later complications perhaps happen at the later end of that window and beyond.
Many of these people that you see will test positive by PCR, but there are some that are negative. Do you feel confident in some of these individuals that they have a clinical phenotype that would be in keeping with the coronavirus infection?
Yeah, we're certainly seeing patients who we're confident have COVID, even if the PCR test is negative. These would be patients with a classical history, with the right time course, and then there would be some clinical features that we'd pick up from investigations that would make us confident to make that diagnosis. And they would be a lymphopenia and classical imaging findings.
In your experience, what are the sort of common reasons why these individuals would test negative?
So we know that the test is not completely sensitive, so there will always be some false negatives, so we're aware of that for all tests, but particularly with this one. And then also the test quality, how well the swab is taken, is really important, and it's not necessarily an easy test to do well, so it's quite a deep swab. So if that's not done brilliantly, we might miss some cases, and so we would certainly always go on the clinical features, and we'd be confident to make that diagnosis of COVID.
And looking back over the past weeks and months, are there any specific features that you look out for that would give you an indication that someone is at particular risk of progressing to organ failure or even death?
Yeah, so there are patients that we are more worried about when we see them admitted or as they progress in their admission. And they would be people who either have comorbidities that would make us more concerned they're at higher risk of multi-organ dysfunction, particularly patients with diabetes, hypertension, cardiovascular or respiratory comorbidities. And obviously those of older age are at greater risk of becoming more unwell. And then there are blood tests that are very useful for trying to indicate who might already be a concern to us at the date of presentation, or those who, as their bloods change, we'd be more concerned about. And the things we would look out for would be a very high D-dimer and a climbing D-dimer, a raised troponin, developing an acute kidney injury, and of course rising CRP. All of those would make us concerned that someone might need high-level care.